And we will go from these very practical dilemmas, which stem among others from incomplete understanding of a disease, to talk about a technique which can be used to better understand the pathophysiology of nerve damage. And maybe in the future, it could become a tool for assessment of prognosis or response to treatment. And the talk on measurement of axonal excitability will be given by Dr. Mihai Moldovan, professor at the University of Copenhagen, with ample experience in this field, also one of the authors of a recent consensus guidelines published in Clinical Neurophysiology. So, Professor Moldovan, please enlighten us.
Good evening, everybody. First of all, I would like to thank the organizers for inviting me to this very interesting clinical neurophysiology symposium. I'm talking to you from Copenhagen, and as you can see in this picture, there are two arrows. This is the University Hospital in Copenhagen, Rigshospitalet, where we do the clinical work, and here is the Institute of Neuroscience, where I do the other part of the work. So my talk is going to be somewhere between these two buildings. And the talk is about a new way of understanding electrodiagnosis of peripheral nervous system, and that's the nerve excitability studies. As we all know about these nerve conduction studies that we are now clinically used, and because they are very simple to understand. I mean, you basically have nerves are just some cables, and you apply an electrical current, and then you record a response. But we should be made aware that some time ago, 50 years ago, it was not the nerve conduction studies that people will use for electrodiagnosis, but other types of studies called nerve excitability studies, as we can see here. From 52, the assessment of tissue excitability and what is termed accommodation. So things have changed, and somehow this information was lost, and there was a big struggle to bring back this lost knowledge of nerve excitability studies. And this we have done with this consensus paper last year, which culminates about 20 years of research and experimental development. So I can now safely say that these methods have now come from research into clinical practice. And all it was possible because of Professor Hugh Postock from Queen Square Neurology, who I would like to praise in this slide here, and as well as the group from Copenhagen, where is Professor Christian Krarup, and who was a student and follower of Professor Fritz Buchtal, who you all know about his developments in EMG. So peripheral nerves have axons. Axons are very different, and we have heard about the small fibers, myelinated fibers, but this is anatomy. From the functional point of view, would like to say that in a peripheral nerve, there are some normal axons. There are some axons that do not conduct, which we don't see electrophysiologically. We have some regenerated axons, because in a neuropathy, we always have some regeneration with degeneration. That's the plasticity of our nervous system. But we have some other axons, which are with abnormal function. And somehow it's not something that we think of when we do clinical neurophysiology, but this is exactly the focus of excitability studies. So we try to depict the axons that have an abnormal function, because this understanding the abnormal function in this axon could lead us to the cause of this dysfunction. So basically, nerve excitability studies are a method that, using very basic non-invasive recordings, this is exactly like in the routine nerve conduction studies, can give information about the ion channels that structure, function, and dysfunction that underlie the neuropathy in that case. So as you can see, this is almost too good to be true, and it's obviously a very indirect method, because you are doing a very simple measurement, and you want to infer information about the underlying ion dysfunction. So basically, my talk will try to briefly cover these points. First, I would like to discuss about threshold and excitability. And I would like to say that the basis of all this will be just like a normal recording setup, is the stimulus response curve. And this will be a motor excitability test stimulating the median nerve and recording from the APB. The key of all this is what we call the stimulus response curve. As you can see in this graph here, with increasing intensity of the current, we have an increase muscle response, because more and more axons that conduct impulses to the muscle get recruited until all the axons are stimulated. This is called the stimulus response curve. In a way, we all do this when we do conduction studies. We just go to the maximum because this is what we're interested in. But here we're not interested in the maximum. We're interested in what is called threshold. And just to make a point here, of course, if you stimulate the median nerve at elbow, so with red will be at wrist, with blue here will be stimulation at elbow in a subject, they will have about the same maximum because these are motor studies, but you need more current to stimulate from the elbow. And this would be a shift in what we call the stimulus response curve to a more current. In this study, we did something very interesting to these patients. We have injected lidocaine. This is under ultrasound control. And if you inject lidocaine in these patients, look what happens. This would be the red trace here is stimulation at wrist. But after lidocaine, after a while, of course, is conduction failure, but after the while, the motor conduction resumes. When the motor conduction resumes, you can get the maximum response, the maximum CMAP, but you need a much, much higher current. You can see it's 10 times higher current, but you can get a maximum response. At that time, the patient says, I've recovered from the anesthetic block. And this threshold increase will last many hours. How do we explain this? Well, this is the typical original safety factor for conduction. We have much more sodium channel that we need for conduction. So even if we block a big part of them, 50%, we can still conduct, just at the threshold, the current required to activate this nerve, it's much higher. So what is then, if this is a threshold, what is then threshold tracking? Threshold tracking is the basis of this method, and it was initially put together, the concept by Joseph Berman in the 70s. And basically, this is by analogy with a simple fiber here. As you can see here, we normally think if it's a cell, an axon, there is a threshold potential, and when there is the depolarization is above threshold, you get an action potential. Well, in the case of a nerve, we have the stimulus response curve that we talked about, but then we say, what is the current required to activate a fraction of it, which is about 40–50% of the maximum potential. So this is what we now call a nerve threshold, a motor nerve threshold, is the current required to activate about 40% of the fiber. So a sub-maximal stimulation. Then the genius of Professor Hugh Bostock was to make an automatic method to do this test. So to actually adjust the stimulation current to track this 40%, 50% of the maximum CMAP. And how does this work? Well, you can see, I want to tell the computer I need to find the current that would give me a potential that is about 40%. And then the computer will give a first stimulus. It will give a potential about here. Well, this is too big. Then the current will be decreased by how much? Well, this relationship is pretty linear, so I know how to decrease it. And by trial and error, finally, the computer will actually find this stimulation with this value here would actually give me a potential that is threshold potential. So then our studies that we have seen before, we can put a number to it and we can say, well, after lidocaine, if this is the threshold, then we can find the current required to evoke 40% of the maximum. So after lidocaine, there was an increase in threshold, which is a decrease in excitability. Good. So just as a basic principle. Now, obviously, the absolute value of the threshold is not so interesting, What we are really interested in is the threshold electrode with variations of it, but we cannot inject lidocaine in all patients just to see how the threshold changes. We induce the changes by putting polarizing currents. And this is also something extremely old. For example, in 1882, what you can see in this graph here, this is a chemograph where nerve is hit with a hammer. And you can see here that with adding a hypopolarizing pulse, the response would decrease for the same strength of hammer hit. But then this is not constant, as you can see. It changes. And then this change phenomenon got the name of accommodation. And then how does the advancement was, what is this accommodation due to? And now we know that this is because of all these ion channels that are under the myelin. It's not everything on the node. We know now that there are a lot of ion channels under the myelin, and the node, and most of them, accommodation to depolarization occurs due to potassium channels. And how is this doing it? So this would be a curve recorded in from a nerve. You can see that if this is going to have potassium channels, if this will be just a passive cable, like we'll have a normal nerve with no potassium channels, then depolarization will not have any accommodation. But because of the accommodation, with increasing depolarization, the potassium channels open, and that brings the potential down. Okay, this is theory. How do we actually, to illustrate this, I would like to present a short case. And first of all, how do we actually record it? There is an equipment that you can buy already made. It's a computer, a stimulator, and the recorder. 3 different pieces, but they can be put together. This is very convenient now. It's a convenient option to get a system working. How does it look? Well, this would be a recording. During the recording, as you can see, this is the potential. Here are testing depolarizing pulses, hyperpolarizing pulses during a test. This is a fully automatic procedure, so you just put the electrodes on, press record, and 10 minutes later, this is done. So the computer tests different polarizing pulses, different currents duration, and makes what is called a nerve excitability recording. So recording, again, very easy. What do we get in this patient? As you can see, the patient is depicted here with red. With green here, we have the control values, the values in a big number of control subjects, our own control subjects. You can see this patient is very abnormal here. It's outside of all these control values. So on depolarization, the control values, the threshold is brought back by opening of potassium channels. In this patient, the threshold is not brought back. So, well, I think it has a problem with the potassium channel. And we have normal values for this. So there are excitability indices, they are called. So measure, you see at the peak here, there is no difference between the patient and controls, but after 100 milliseconds, which is here, there is a big difference. There are normative values, there are tables, and about this we'll say, well, this patient has a 3-time increase in one of these indices, and this means that it has an impaired accommodation to depolarization. Fine. So maybe something wrong with potassium channels. Of course, in this case, well, maybe some kind of channelopathy. We called the family. We did the family. This patient is very different than all his relatives. So yes, it cannot accommodate to potassium. So what can we do more? What kind of potassium channel? Well, there are 2 ways to approach this. First of all is to try to look at the literature. Now we have a relatively vast literature with describing abnormalities in excitability by this standardized method. The method is standardized now by 20 years. So we have accumulated a lot of data, and we find, well, patients with KV1.1 mutation, you can see, well, it's not exactly the same like our patient because there is a different at the peak here. It may be a different there, but it's a different. What about, so it's maybe not a KV1.1 potassium channel, a fast potassium channel, maybe it's a slow potassium channel. So we look here in the slow potassium channel described cases. Well, it's kind of closer, but not because you can see there is still some accommodation in KV7.2 mutations. So what do we do then? Can we know more about this? It doesn't really fit with the human data, but then there is a lot of animal study data, and this is part of the things I've been involved in all these years, try to better the understanding of these by animal experiments, because these methods are 100% translational. Then you can find a paper here where it shows that the KV7.3, blocking KV7.3 in a rat, gives you exactly a picture like in our patient. You see there is, this will be green is control, red is patient, no accommodation to depolarization. The same happens in a rat when you block the KV7.3. So, well, maybe this patient has a KV7.3 mutation, but do we trust the animal study data? Can we do more for human data? And we can do something more for human data. We can do more tests. And this, instead of doing just the electrotonus, we can do what we call a multiple measure of excitability tests. And what is this like? Because one channel, it cannot be shown by one picture from one direction, like the electrotonus. If you take a picture from different sides, this is the Little Mermaid here in Copenhagen. By using multiple tests, you can take multiple pictures, and this is how our patient looks from these multiple tests. Well, it is abnormal in this one, but not in this one, abnormal in this one. Okay, what does it mean? How can we approach this? Well, there are tables for this. Some of this can be very discouraging, but yes, if this is up and this is down and this is up and this is down, maybe it's this. It is possible to read it like this, but then I would like to say that this is like the EEG. So you have a lot of data. You, of course, can read the EEG without the aid of computers if you're a specialist. But then by using modeling, you can get a source localization much easier. The same thing you can do these days with excitability data. We have a mathematical model. Based on this mathematical model, you can see, well, if this would be a fast potassium channels, you can make a Forer modeling and say, how would change the potassium channel affect my excitability? And it looks like this. You can see with blue here, how would be changing the slow potassium channels, so the Kc and Q-type potassium channels in the model. You can see the model predicts something that is, well, way closer to what we actually record in this patient. So then we run the reverse model. So we say, please fit our data based on this mathematical model and say what would be the closest interpretation for our changes. And the model comes up with a very clear result here. It's reducing the discrepancy, the error. I mean, so how good the fit is. You can see here with red is the model fit, with error, with round boxes here is a recording from the patient. And then the model has predicted that, well, it's a serious decrease in the slow potassium channels. So by doing this, you say, well, we have a patient here that came with an excitability problem, and then we have managed to say that, well, the conduction was borderline abnormal, like we have in this patient. So then it had some kind of a strange neuropathy. Then the patient was sent. This will be the reasoning in our case. Then was sent. Well, try and see if excitability can help you. And why do I say can help you? Because you saw that it's very easy to record. It takes 15 minutes for the patient. It's not invasive. But then you get a recording which requires, like in EEG, some interpretation. And this interpretation can take some time, and you can be lucky to find something in the literature. If you don't find it in the literature, then neither human nor animal, then you'll have to do this mathematical modeling, which is also software implemented like you would do in EEG source localization. And then you get a hit. If you get a hit, then you can be proud to send the patient with a diagnosis like this, that this patient has an impaired accommodation to depolarization due to a reduction in slow potassium currents by 85%. Yes, the model is quantitative, so you can give an estimation of how big the abnormality is, consistent with a severe KCNQ3 channel impairment. So this is a fantastic electrodiagnosis that you can give after a 10 minutes non-invasive recording in a patient. And this is why I think that these are very powerful methods that can be used to diagnose channel mutations in patients. So of course, it's not for all patients, but in some patients, it can make a very big difference. Thank you.
Okay, thank you very much for an excellent lecture. Do you think with this method what is needed is pooling of data from different centers and then doing some big data analysis, or not really big data, just establishing international standards? Is this plausible, possible regarding the technology of the method?
Yeah, absolutely. So the method, since 2000, the method has a standardized protocol.
Okay.
So all the recordings carried out by different centers around the world. Now I think we have about 30 centers around the world that do this method. Have recorded precisely the same protocol since almost 20 years now. So we have a big amount of data. What has changed in time in these 20 years is that in the beginning, it was very difficult to understand what the data meant. So of course now, because the data is recorded in the same way, and the knowledge has been developed so much, on one hand, because of the animal studies where people like me and others have done pharmacology mutations to see exactly how would this affect the measurements. Mm-hmm. We now learned a lot, so we can now go back to data. There are several initiatives actually to try to pull this up in some big centers. There are of course problems with patient sharing of patient data across continents and all this, because things are, I mean, there's a big group in UK, a big group in Australia, and us in Europe as major groups, and then there is Japan. So it is to put things together. It's but yes, we have thought about this, and there is an effort. But now, I mean, the machine comes with normal controls in the 30 to 100 normal controls values. So you know there is an abnormality, very precise. It's that's what was the consensus last year, because we really reached the point we know when something is abnormal. Where we may struggle is to understand what the abnormality means. But there is no doubt that, so yes, there is standardization. Okay,
so you mentioned there are about 30 centers performing this method around the globe.
Something like that. There's these big ones, and then enthusiast doctors in different countries that are now getting this interest in trying this. We are running now a multicentric trial with 20 doctors from different centers.
So how do you suggest any enthusiasts in our public can go into this field?
There has been, in a way, after public, we were really hoping that after this this consensus was published, to try to organize some kind of courses. We were speaking with Professor Hugh Postock and Hatice Tankizi here, also from another city here, to make some kind of a yearly course for these things, and like a workshop or specialized course in this, similar to like a single fiber type development. Mm-hmm. But then difficulties with the current pandemic have somewhat derailed this plan, but we hope to get back on track.
Okay, we have a couple more questions. Have you done genetic testing in these patients you have mentioned, you have shown us?
In this particular patient, no. We were in a way too confident, so we didn't. We had we didn't do it, but there are cases in which we are not so sure, and we did genetic tests with which fit. Where we have most in doubt is that when an abnormal ion channel happens due to antibodies, we have sent, because this test will tell you that there's a certain dysfunction in a channel, but it will not tell you if it's a mutation or an antibody type. And these antibodies are complicated because it's not always loss of functions. It can be with abnormal functioning and other things. So yes, we are collaborating, for example, with Angela Vincent from Oxford, where we sent for antibody testing, and for this particular cases where things are not so obvious as in the example that I gave you.
No.
But when it's an example like this, we didn't.
There's another question. You mentioned channelopathies. Do you see the use of this method in other diseases like CIDP or other neuropathies?
Oh, yeah. Well, thank you for mentioning CIDP. We have a running study now. People have tried it before, but CIDP is to do what? Is, for example, to track the response to IVIG and separate and so for prognostication and stratification, not for pathological assessment. But things have been developing quite interesting. For example, also because a lot of pharmacologies that we have studies running on, for example, patients which have epilepsy and have a mutated channel that does not give them a neuropathy, but is expressed in peripheral nerve. So you can diagnose a genetic epilepsy at the nerve conduction test, which is quite interesting as a thought. But so yes, there could be, because this method, this is what can tell you is how these ion channels that we know that they exist in the nerve, in the motor. We prefer the motor system and APB for various reasons, but I mean, it can be done in sensory fibers. It has been tried. Also, Jordi Serra from Spain, he was Barcelona. He was very interested to try a psychophysiological tracking. So people would you would not record a muscle response or a nerve response. You would record a psychophysical response, and patients will turn a button and click when they feel, and that current would give you very similar curves to this. So that would be a psychophysiological term. But this is kind of the research has. Let's say, fueled a lot of enthusiasm recently, and it's a growing field. I just focus on something that, so there is a clinical part, which yes, can be useful, but the research part, it's also fantastic. So I think it's a train that will be interesting to get into now, because there are still things to be discovered.
Okay, thank you very much for this wonderful lecture, and to show us that sometimes we have to go back 30 or 40 years to see what has been forgotten, and then start using it again, and not just check the first 2 pages in PubMed. So thank you very much again.
Thank you.